think we have everyone up here. I'll introduce the speakers as we go, but I wanted to introduce two of our panelists that are down here as well. So Dr. Katie Berlacher is our director of our cardiac fellowship, cardiovascular diseases fellowship at UPMC, and a card-carrying cardiologist. And next to her is Dr. Elizabeth Bacone, who is also a cardiologist at UPMC Jameson, and more recently wears the hat of president of the hospital as well. So thank you both. We're going to rely on your expertise on how to manage these cases as they go. Our first case is by Dr. Barrington. He is one of our senior members of the electrophysiology group and the vice president of medical affairs at UPMC Shadyside, and is going to talk about device detected AF case. Thank you, Bill.
Thank you very much, Sandeep. So what we want to talk about a little bit is the device detected AF. Anticoagulation is the issue. Kind of what do we do about it? I think I have to echo Dr. Beausoleil's comment this morning. This is a headache for us, and there's not much we can do about it. I have no disclosures, but I would like to start with this case presentation where JA is a 90-year-old woman. She has a history of hypertension, hyperlipidemia, but no evidence of diabetes, heart failure, stroke, and has never had a TIA. She's actually a very healthy woman with a normal EF, lives independently with her husband, and is quite active. Now, in November of 2021, she developed symptomatic heart block, and at that point, we put in a dual chamber pacemaker. Her post-op wound and device check was perfectly normal, and we did our standard, which is enroll her in home monitoring. The problems began when we saw her first remote download on February 21st, where she had 708 episodes of AT-AF. The total duration was for 7.2 hours, but her longest episode was just a little under 8 minutes. We pulled up some of the data. This is part of the histogram display that tells us the episodes. So they were there. The thing that kind of was surprising is the episodes looked really short. So we kind of wondered what was really going on. But when we pulled up the actual recordings, you could see it truly was an atrial arrhythmia. So the question became, what should we do? As Dr. Beausoleil and others have talked about, our current guidelines are really designed to only consider if AFib is present or absent. And once you make that determined, then you go on and you evaluate the other clinical variables that are involved. Now, remember that CHADS and the CHA-DS-VASc scores were truly developed based on clinical atrial fibrillation. And by that, I mean AFib that we discover because a patient comes in with symptoms, or we're doing some other kind of incidental recording, maybe doing an EKG, and we say, oops, you're in atrial fibrillation. All of that was fairly straightforward. The problem became with the increase in the number of cardiac implantable electrical devices. We're now identifying what we're calling subclinical atrial fibrillation. They have this ability to identify what we call atrial high rate episodes. So what happens is the device can look on the atrial lead and can tell if there's something that's going on too fast. Realize it may be AFib, it may be a flutter, it could be some kind of SVT. The question really for us is, what do these subclinical episodes mean in terms of the stroke risk? Because I think many of us feel that the major problem we have to address with AFib is minimizing the stroke. So how do we judge the clinical importance of these subclinical atrial fibrillation episodes? The questions kind of remain, should we simply treat it like the clinical AF and just apply the CHA DS-VASc guidelines. While that may have some advantage, there are some observational studies which Dr. Beausoleil referred to that suggest there is a slower risk with this subclinical AFib than what we expect with the usual CHA DS-VASc scoring. So the question is, should we factor the burden of this subclinical AF into our antithrombotic decision-making? And in fact, while we have a well-defined CHA DS-VASc score, there are some people that have suggested we developed a CHA DS-VASc AF burden score, none of which exists at this point. So let's talk just a little bit about defining the AF burden. If you go back to the old days, we actually didn't worry too much about AFib until it was over 48 hours. Clearly over time that has changed, and there was a continuum from 48 hours of AFib down to no AFib. And what's become significant has really evolved over the past few years. Some people talk about 24 hours, some people talk about over 6 hours, some talk about 5 or 6 minutes. There are some that even talk about the presence of even 1 minute of AFib being significant. So what I'd like to do is just take a few minutes to look at a few of these attempts to develop a definition of what is a significant AF burden. Again, Dr. Beausoleil talked a little bit about this, but what excuse me, I'd like to start with is the ASSERT trial, where they enrolled almost 2,500 patients, had a mean follow-up of 2.5 years, and basically it was a population that we would be interested in. All of them were over 65 years of age. All of them had a history of hypertension, but none of them had known atrial fibrillation. When we looked at those patients, however, we found that out of the almost 2,500, 893, in other words, 36% of the group, had an episode of subclinical atrial fibrillation. Actually, these were what we call the atrial high rate episodes. They didn't really go back in and examine, and couldn't in some cases, the actual recordings to see if this was AFib. While that was the case, they found that 462, or 18% of the total, had an episode that was more than 6 minutes and up to about 6 hours in duration. They basically ignored people that had less than 6 minutes of atrial fibrillation. They found that almost 7% of the total had an episode that went from 6 hours up to 24 hours. And as you might expect, there were some that had 24 hours or more of atrial fibrillation, and that constituted 262 people. Now, their clinical endpoint for the study was the presence of a stroke or some kind of systemic embolism, kind of an endpoint that we would be interested in. And what they found is that if you go and look at the study that's shown here, there doesn't seem to be a lot of increase in the cumulative event rates, which is on the left-hand axis of the graph, if you were talking about people that had AFib less than 24 hours. However, if you had atrial fibrillation for 24 hours, you had a yearly calculated stroke risk of 3.08%. Now, that is in comparison to a very low stroke risk of those that had no AFib. Now, when you think about it, 3.08% may not sound like a lot, but remember, the current guidelines suggest that a CHA DS-VASc score, which gives you an annual stroke risk of 2.2%, is an indication for anticoagulation. So at this point, are we now having evidence that an atrial high rate of more than 24 hours duration on the device is enough to go and indicate an increased risk of stroke that we ought to treat? I think many of us feel that that does become a long enough period to worry us. However, people weren't satisfied that the 24 hours was good enough. So other periods were looked at. The TRENDS study, ended up taking another 2,500 patients. All of these were those with a new cardiac implantable device. They were all 65 or older. 40-some% had a history of AFib, and all of them had at least one risk factor for stroke based on the CHA DS-VASc score. And in fact, the average CHA DS-VASc score was 2.2. They then basically divided the groups up based on the longest episode of atrial fibrillation. And basically, they divided it up into those that had no AF, those that had a low burden, which they defined as less than 5.5 hours, or those that had a high burden. And when you went and looked at the data, what you found is that those that had a 0 or low burden of atrial fibrillation had about a 1.1% annualized thrombotic risk. However, if you had that high AF burden, greater than 5.5 hours, the thrombotic risk was about 2.4%. Again, we're into the same range that our CHA DS-VASc score of 2 uses to justify the placement of someone on oral anticoagulation. So now this raises more issues. Does this mean we have to deal with 5.5 hours is the point where we end up going and starting anticoagulation with this subclinical AF? Well, to confound issues further, the MOST trial looked at some other individuals. So let's see here if I can get it to, there we go. Nope, I guess we go this way. There we are. All right, there. All right. MOST examined a much smaller subgroup of patients. It took 312 patients in their initial subgroup. They had a mean age of 74. And they followed them for a little over 2 years. What they were looking for was what happened if people had even one atrial high rate episode, which they defined as a heart rate of over 220 for greater than 5 minutes. And they decided they wanted to look for the effect on total mortality, health or non-fatal stroke, or development of atrial fibrillation. And if you look at that study, it turns out that if you had even one atrial high rate episodes, you were more prone to these events than what the people that had none did. If in fact you looked at total mortality, the hazard ratio for one event was 2.48. If you looked at death, the hazards ratio was 2.79. And if you looked at the possibility of the development of atrial fibrillation, that was 5.93. So I think now we're going to have to worry, does even 5 minutes of some kind of an atrial high rate episode mean something? So that's kind of a quick look at what's out there in the literature. But I guess my question for you is, did I help you figure out how to handle these device-related episodes? My personal feeling is I probably didn't really. I think I have managed to make people more nervous about seeing any atrial high rate episodes on your devices. I think that's probably the bad news out of this. What's the good news? I think the good news is it still means we need to stay doctors. We need to be able to involve the patient, look at the various risks and benefits, and decide in each case where we're going to go. Probably the last question people want to know is, what did I do with my little 90-year-old lady? I put her on Eliquis. And I think all of us feel that's a much better approach. So thank you. And I don't know whether we want to do questions later.
Yeah, we can maybe start with one. So I'm going to address this to Dr. Picone. You have a lot of device patients in your clinic, and you get these letters from our device interrogations, and you see, oh, we noticed some AFib on somebody that has no symptoms, Bill's 90-year-old patient. How are you deciding? Are you calling back that device clinic? Are you looking, do you have the time to look at the details of what's written in that report to decide I'm going to put somebody on anticoagulation or not?
Yeah, the first thing we do is look at the company it keeps. Who's the patient? Are they 90? Are they 60? What other medical comorbidities do they have? And then just like you would notice, we like to see, was it really AFib? Like, what are we actually looking at? Is it just an atrial high rate? And look at that information. So it's very helpful for us that it's in there. And then we make the decision after talking with the patient, really with, if this was a 90-year-old with frequent falls, right, we would say, no, we're not going to do it. But I agree with you 100%. I would say that a patient like this fears loss of independence more than anything and fears stroke more than probably anything else. So we do look at that and we track it. So even if we're not 100%, haven't come to a decision with the patient of what to do right now, we flag it so we can track it to see what's going on. We also follow up with that patient to make sure they're actually really not symptomatic, because a lot of times if you say, do you ever notice this, this, or this, all of a sudden we find that there may be more underneath it.
Yeah, no, that's great. I think as Bill mentioned, it's nuanced to the patient and what their comorbidities are and where we go from there. And I think this will come up again later. I want to move on to our next talk.